Good morning, everybody, and welcome to Beyond Telehealth. And I'm Lisa Finkelstein. I'm going to be your host this morning, and we're going to talk about telemedicine, teleurology, where telemedicine is medicine. This morning, we're going to talk about the future state of telemedicine. And I'm honored to have my friend Jennie Bepple, who's going to introduce herself. So Jennie, tell us what specialty you practice, where you practice, and why do you love telehealth?
So Lisa, thank you so much for inviting me on today. I always love speaking with you about telehealth. So my name's Jennie Bepple, and I'm a urologist, and I practice outside of Baltimore. And I serve as a director of digital health for United Urology, which is a single specialty urology group that is in Colorado, Arizona, Maryland, Tennessee, and Delaware.
Wow. Okay, so why did you get interested? Why did you become interested in telehealth, and why do you love telehealth?
So I became interested in telehealth really for both, personal and professional reasons. I was seeing a huge challenge of access to care. So access to specialists. As you know, over 60% of the counties in the US don't have a urologist. And even places that have a urologist, it can be tough to get in to see the right one, so the right specialty. So there's challenges with access to us. There's physician shortages and such. But the other part is really just being sensitive to the needs of my patients. So patients having to take off a half a day to come into the office, struggling to find childcare, struggling to even have the time to be able to take off were really like my motivating factors. And then I saw that in my own personal life, we even chose the area where we're going to live based upon the medical capabilities here.
You mean for your children, for your family?
That's correct, for my family.
Right. So have you used telemedicine for your family?
I have, and it's been great. When you have children who have certain health conditions that require more regular follow-up, it's a blessing not having to take off and getting the same level of care and input for them.
Right. So as a busy mom who is a physician, a urologist, having to schlep your kids to an office is a major disrupting factor in your day. So telehealth can help with that.
Absolutely. Obviously we would do anything for our family. And I was I'm friends with a lot of people who may not have the opportunity to be able to take off to go to another appointment. And so, yeah, it's been a game changer.
Wow. Okay, so let me ask you one more question, then we're going to go into the future state. So in your urologic practice, one of the questions that I would ask a lot of the physicians is, what EMR do you use? And do you use telemedicine through your EHR? And how have you incorporate telehealth to be successful in a urologic practice?
So we use Allscripts. Our telehealth is not through Allscripts, however. We use Freesia as our pre-registration solution and have a very talented software developer who used the Zoom partnership with Freesia to build a customized dashboard so that we're able to have patients go through the same pre-registration that they would for the office, in addition to a consenting process there that then gives them their unique entrance into their Zoom link.
That's so funny. Freesia, when Freesia first started, I was, oh my gosh, Jennie, that you're talking, I'm going to say well over 10, 12 years ago. It was that tablet that you sign in. Yeah. And it was free. And I'm like, I always forget about that. That maybe was my first step into telehealth, into digital health.
Yeah, I mean, it certainly saves patients time sitting in waiting rooms and things, just doing any type of pre-registration, but certainly on telehealth, it's key to be able to, again, make sure you get the same information and that there is some interoperability with your EMR so that you're not having to redo past medical history, medications, allergies and such, and still getting all that important information.
Right, because it's so annoying having to fill out those forms every single time.
That's right.
All right, let's now dive into the future of telehealth. Let's talk definitions. I know it's boring, but even as physicians, I think a lot of us don't understand when we say AI. How does that work? Machine learning. These are terms that a lot of physicians are confused about. So run us through some of these things that you can help us understand.
Sure. I mean, I think that this is an exciting part of not just telehealth, although it is a piece of telehealth, but of digital health in general. And so talking about the patient's total health journey and how can we make it better. And some of that starts with a virtual first concept, which means, seeing them in some area of telehealth, whether that's synchronous or asynchronous. So that's sort of your first definition. So synchronous is the classic stuff where you're talking live with your physician. Asynchronous telehealth is, where it's oftentimes a questionnaire based or AI, artificial intelligence supported. So artificial intelligence, think of it as like a big umbrella definition that kind of has all of this data that you're able to kind of filter through. So it's all the algorithms that are built. Within that umbrella is then machine learning. And machine learning is just a subset of it. So think of machine learning as, like your Amazon subscription. So it learns what you like over time and then presents you with what it wants, versus artificial intelligence really kind of takes you on a strict algorithm. So if you're going on to, for example, like a direct-to-consumer site for men's health, for erectile dysfunction, it will take you on this kind of journey and kind of kick you out of the journey to get a prescription if you have something that we know would be a contraindication. So you're on nitrates, for example, so then it would kick you out. Versus, again, the machine learning is it learns your preferences. And then the next kind of level under that would be deep learning. And deep learning is, think of it as the self-driving cars, so it really is kind of functioning like your neurons and making decisions as it goes. Where this all fits into medicine, and in urology, we've seen several papers out in AI, is that it also fits into radiology reads and it fits into pathology reads. So we've seen things coming out with prostate cancer, for example, and just decreasing, how pathologists sometimes have different reads, and it's kind of making that more consistent. Now, there isn't anything out there where it is the final diagnosis, but it's looking at, again, kind of reducing errors across different specialties. So we've seen it there. We've seen it coming out with kidney cancer. We've also seen it even in stone prediction. So what's the likelihood of a stone passing, for example, can be put into it. So AI can be seen in those things in our pathology and radiology reads. It can be part of the asynchronous care. And the other exciting part about AI is where it fits onto clinical decision support tools. So that's what can be in EMRs. And one, really popular one right now, for example, in Epic is like the sepsis tool. So that when a patient comes in, as you go through and you say, okay, these are the lab values and vital signs and presenting information, and here's the likelihood that this patient has sepsis. So it's trying to reduce your risk of missing, an important medical event. And so the other part where it can help you is if you were, for example, to put in a diagnosis, and it may give you options. So I have low risk prostate cancer. Okay, so what are my kind of classic options in treatment of that? So it's really kind of fascinating how it's going to be changing medicine.
So two things come to mind. One is many years ago when Watson won Jeopardy, and Cleveland Clinic had these aspirations for Watson, IBM Watson, to come in and round with residents and attendings, and through this machine learning, be able to assist, just like you're talking about, in diagnosis and differentials and things like that. And I know, I followed it for a while, but it wasn't what they thought it was going to be. So can you comment, because in that piece that I wrote a couple weeks ago, that op-ed, one of the comments was that doctors are going to go by the way of the toll booth. So I think a lot of physicians are very fearful when they hear these definitions of what's happening and that machines are going to be learning and helping. That what do we need physicians anymore? What do we need urologists anymore? There's a lot of fear and anxiety about that.
Yeah, no, I understand that. I don't see physicians as being replaced by any means. I think that the word, you use is it's meant to help physicians, so it's meant to help reduce, medical errors. It can also help to reduce medical waste. So, that if there are basically standards of care for ordering certain imaging, it kind of helps you along that as well. I think that there is so much to know in this field that it helps to provide really patients with safety so that when they're seeing a physician, that it's consistent care, right? That you would get the same care, whether you are being seen at the Cleveland Clinic or you're not, and you're at a smaller town. And so I think that the technology can help with some of that, but certainly, physicians aren't being replaced. There is clearly still an art to medicine, and there needs to be personalized care. So, it's not one size fits all. And to some extent, some of the machine learning is part of that. And that's where the physician sort of steps in, recognizing the priorities and concerns of their patient to be able to give that.
Another piece that is always brought up is that we're losing the touch, right? We're losing the physical exam. We're losing that in-person, real-life relationship. And those of us that are champions of telemedicine recognize that it's not one size fits all. That telemedicine, digital health is not just the way it's going to be, that there is this hybrid model. What do you think about, how do you talk about physicians educating them about what is the right patient, what is not the right patient?
Yeah, I think that, private practice physicians are in the perfect spot to be able to truly do what I think will be the new standard, and that is a hybrid model. I don't think we're going to lose our physical exam. We're still going to have like our Bates books for, important parts of the physical exam. And that really is very important to some of our diagnoses. But the fact is that for some of our diagnoses, it's not critical. Some of it is very image-based, for example, or it's reviewing, pathology in labs or prescription efficacy. And so that doesn't always have to require a physical exam and an in-person visit. So I think that it does take some practice to learn how to build rapport with your patients over, the screen. But it certainly is very feasible, and I found it to be very rewarding.
Yeah, I think that the pivotal moment for me, and I have said this in a couple of these broadcasts, was when I first started getting into figuring out how this was going to work. And quality telemedicine to me initially it was for my established patients that I knew, that I loved, that I touched before, and then, bringing them back. And then I had a conversation with a mom who was a secretary for our CEO and has 3 children, and she's 35. And she said, Lisa, if I never have to go in to see a physician, I'd be happy. And I was like, really? It was this like light bulb that went off in my head. And so let's talk about the next thing, that's the next model that we're talking about, which is bringing healthcare to the patient, making it convenient for the patient in their home, which, and we've talked about this, is that going by the way of the banks and the way of shopping. And in my world, it took me a while to figure out that I'm just going to be using my phone to bank. I never ever have to go into a bank again.
No more lollipops.
Right. Exactly. No more free cups of coffee.
That's right.
And so, but everyone has made that, not everyone, but many people have made that leap. And that's true. Not everyone. Or shopping online. Like, we cannot ignore Amazon. We cannot ignore Google. We cannot ignore these major corporations that are disrupting and will disrupt healthcare, and the companies that are bringing direct-to-consumer healthcare to patients. So what's your opinion on that?
Yeah, I think you're right. I think that we can't ignore how people are now interacting with society, right? And it's how they interact with their groceries. It's how we exercise. You know, you don't have to go to the
Right.
gym. You can do yoga online. It's every sort of aspect. And so we would really be naive to think that the same level of convenience isn't also wanted with healthcare. I definitely think that the trend is moving healthcare into the home. And I think that that's both for the sick and the healthy. You know, there's a big movement towards, moving hospital care to the home. There are certainly advantages to being in your home for some of that care. There's also advantages to bringing medicine into the home to prevent people from going into the hospital. So, remote patient monitoring, mHealth, mobile health, and things are designed to try and answer some of those challenges. And then, for our healthy folks who may not need to see a provider very often, except for maybe something acute here or there, certainly there are benefits there as well. But the marketplace is really speaking between the popularity of the direct to consumers, as well as really the popularity with a lot of these wearables.
I'm going to bring up the doctor skeptic in me as well. So you showed us a website with a medication for overactive bladder that was speaking directly to the patient when they were engaging in their website, that said, if you have free medication, then you can speak to a provider. Click on this, right? Well, that provider is not their urologist that they necessarily have a relationship and love, that they're just talking to who knows. And a lot of physicians are offended by that. And a lot of physicians are worried by that. And a lot of physicians feel that it is sort of like the dumbing down of medicine, in that, now you can just have a prescription by somebody who really doesn't know your medical history, the details of your health, and potentially could lead you to have more testing, right? Because it's not the right medication. And so it could cost the healthcare system more money and more time. So there's the flip side of that.
Yeah, so I think several points are kind of in there. One is sort of the watering down of medicine. Whether you are a provider on a virtual health platform or whether you are a provider in an office, you certainly uphold an oath to care for your patients. And in order to care for your patients, you still need the same level of information about them. That is certainly obtainable online. And clearly it's a responsibility of those various platforms to provide that care. The second piece of this is you bring up a really good question, and that is, what is, we think that there's a downstream benefit, right, to virtual care and perhaps virtual first and these, the remote patient monitoring and such, but the data is not mature yet. So what we really need to see, and it's starting to come out, is we need to see if we, truly prevented someone from going into the hospital by seeing them and providing them with faster access to care. And that's, we've got to keep working on that data.
One of the interviews that I did that I loved was with a cardiac nurse practitioner who worked in a cardiology practice in outside of Philly. And then the next I interviewed was RNs that help support her with patients in the home using RPM, remote patient monitoring, for patients that have CHF, pulmonary hypertension, who are chronically ill, chronically sick, and bounce back and forth, to the ER and to the hospital. And fascinatingly, their program has been out there for 6, 7, 8 years. So it was sort of started on a whim, but talking to her, that they have enough data now to know that just by tweaking their medication and, checking in with them twice a day or whatever the plan is, that they have thwarted many ER visits, office visits, extra travel, all of those things, ambulance things. So there are places out there that have that information. It just hasn't been publicized robustly. But that's sort of, I think we know that in those types of situations that those avoid expensive emergency room visits.
Yeah, I think, in that 5% of the population who might utilize kind of 70% of the medical resources, there are certainly good models out there, and you certainly identified some of the best use cases for it, like the CHF is a great one for it, but COPD and monitoring of their lung capacity and such are really good use cases. So I think if you look at those high utility use cases, you can certainly have a wonderful return on health for patients and avoid hospitalizations. I think probably where the question remains is sort of at the bottom of that triangle is, how much data do you need on a regular basis to prevent, further downstream type of medical complications?
We're gonna leave with one example and then we'll call it. And so I was able to help watch and help and assist with a telemedicine visit with a nursing home patient that was readmitted. And the secret sauce was that we had a biomedical engineering student that was helping the nurse at the bedside with the telemedicine cart. So I'm just going to, give this scenario for the listening audience, and that is in this telemedicine cart, which is similar to the telestroke cart, where they have a camera on the top that swivels and zooms and can be controlled by the physician on the other end. On the screen was the family physician, the geriatrician, who was helping admit the patient. The nurse was at the bedside. I was there with the biomed student. We looked in the patient's ears with the teleotoscope. We listened to his heart with the telestethoscope. We looked at his trach site and his peg site with the high-def camera. And we did a full history physical readmission virtually with their physician. It worked.
Yeah. I mean, you nailed it. You used kind of telehealth at sort of the top of its utility. You were able to coordinate care and provide probably, arguably better care for this patient. Yeah, that's the holy grail of telehealth.
Yeah. The big thing was, though, it took a village to get this to happen. It wasn't easy, and I think it will get easier. The other component of that is remote supervision for medical students and residents, which is another passion of mine, is to teach students and residents how this works, because they're just learning as well.
Yep, that's great.
Yeah. So give us some words of wisdom for our skeptical urologists and physicians out there about the future of telemedicine.
I think that telehealth and virtual health is certainly here to stay. It is best to be able to kind of adapt it into your practice. And what I would encourage people to be is, you've got to be patient, you've got to be flexible, and know that just like any other innovation, we're not at final state. It's continuing to evolve. And physicians need to stay engaged in that conversation so we get the best product for our patients at the end of the day.
I would echo that. I think physicians need to be involved in the conversation. As we know, if we're not at the table, we are part of the menu.
That's
and
right.
So we want to help drive the bus forward. So thanks, Jenny. This has been exciting. And stay on for 1 second, okay?
Sure. Thanks, Lisa.
Okay. See ya.